Hello, everybody. My name is Mohamad Mohty from the Saint-Antoine Hospital and Sorbonne University in Paris in France. And it's my great pleasure to welcome all of you to this webinar dedicated to a myeloma summary after ASH 2018. This webinar is run under the activities of the International Academy for Clinical Hematology. Multiple myeloma has been again a matter of a lot of debate during ASH 2018, held recently in San Diego in the United States. More than 900 abstracts and presentations were dedicated to this disease. Here, in the next few minutes or so, I'll try to give you a summary about the major presentations. Obviously, there's always a selection, and some very good presentations will not be presented in this webinar because of time limitation. So I'll start first by giving you an overview about the frontline management of patients with transplant-eligible multiple myeloma. Just for the sake of introduction, I would like to highlight that the patients who are eligible for auto transplant usually these days undergo a very well-defined sequence, which starts with induction, followed by stem cell mobilization, then high-dose melphalan and reinfusion of the autologous stem cells. Then we have the post-transplant therapy, including consolidation and maintenance. During this ASH 2018 meeting, we had a lot of novel data related to novel induction regimens. One important presentation was about the GRIFFIN trial. So we all know that VRD, bortezomib, lenalidomide, dexamethasone, is the standard of care for induction in most places in the world. This trial is actually testing the combination of Daratumumab, a monoclonal antibody directed against CD38, with VRD. So a novel induction regimen called Dara-VRD. And this presentation highlighted the very good safety of this Dara-VRD regimen. There were no treatment discontinuations due to adverse events, and mainly few infusion-related reactions were reported, as it is usually described with the use of Daratumumab. All the other side effects were similar to what you would expect with VRD. In terms of efficacy, at the end of induction, the overall response rate is more than 90%. But when you look after consolidation and after or during maintenance therapy, actually, there is an impressive rate of stringent CR, more than 60%. And responses continue to deepen over time. And most importantly, and this is in relation with the importance of achieving negative MRD, actually, at the end of induction with this Dara-VRD regimen, almost 20% of the patients were MRD negative. And we know that MRD negativity is likely a surrogate marker for extended survival. Another important study related to induction was also presented during this ASH meeting, and this is the LYRA study. So we know that VCD or CyBorD is another popular induction regimen, and the concept of this trial was to test the Daratumumab CyBorD combination, or DARA VCD, as shown on this slide. Again, when it comes to tolerance and safety of this regimen, actually, whether you consider the non-transplant eligible, the newly diagnosed myeloma patient, or the relapse patient, because both groups were included, actually the results were similar to what you would expect with VCD, especially in neutropenia related to the use of alkylating agents. So again, this Daratumumab CyBorD combination appeared to be safe and could be administered in a community setting. The response rate of DARA CyBorD is shown here. In the initial cycles, you have 44% VGPR or better, and at the end of induction after 6 cycles, you could expect up to 56% VGPR and 9% CR. Obviously, these results are likely lower compared to the DARA VRD, but I would say this is expected. Another option for induction would be to replace bortezomib with ixazomib, which is a second-generation proteasome inhibitor, an oral proteasome inhibitor. And this was presented in this phase 2 study by Dr. Kumar and colleague, testing Daratumumab, ixazomib, lenalidomide, and dexamethasone, DARA IRD, using this schema. When you look to the response rates in this trial, actually, it looks like this quadruplet combination is well tolerated, easy to use, didn't impact stem cell collection, and most importantly, allowed to achieve almost 70% of more than VGPR, including 11% of stringent CR as best response. So it looks like the Daratumumab-based inductions regimen are likely to make it into the transplant setting in the near future. When it comes to consolidation and maintenance, we had also a few studies looking into this issue. This is a study testing consolidation with IRD, ixazomib, lenalidomide, dexamethasone, and maintenance with ixazomib or lenalidomide, which is usually the standard of care for maintenance. And actually, when you look into the results of the consolidation, you can appreciate that the full oral combination of ixazomib, lenalidomide, dexamethasone actually was very effective and led to MRD negativity in a significant number of patients. When it comes to maintenance, actually a major presentation during this ASH 2018 meeting was the Tourmaline MM3 phase 3 randomized trial, which was actually published very recently in the Lancet. And this trial tested the use of oral ixazomib as maintenance versus placebo in adult patients who is newly diagnosed multiple myeloma who received high-dose chemotherapy with melphalan and auto-transplant. The primary endpoint was progression-free survival. Here are the patient characteristics. Obviously, this was a randomized trial, so the characteristics were balanced between both groups. When you look to the features of the disease, the high-risk features were also roughly balanced between the two groups. And I'm showing here the results of the primary endpoint, PFS, which is in favor of the ixazomib arm compared to the placebo, with a hazard ratio of 0.72, so roughly a 30% improvement using the ixazomib maintenance. And actually, looking into MRD negativity, those patients who could achieve a negative MRD and who received ixazomib maintenance are likely enjoying the best progression-free survival. So these results are really very interesting and attractive, because we know that in many high-risk patients, the use of a proteasome inhibitor is likely a good option for maintenance, although we all know that for the moment, lenalidomide is the standard of care for maintenance after auto-transplant. In the transplant setting, during this ASH 2018 meeting, another important study was the Forte trial, presented by Dr. Gay and colleague on behalf of the Italian cooperative group. So this is a randomized trial in the transplant setting, looking into 3 arms: KRD, carfilzomib, lenalidomide, dexamethasone, induction, consolidation, and maintenance. No transplant in this arm, versus a transplant arm with KRD induction, followed by auto, followed by consolidation, compared to another induction with KCD, carfilzomib, cyclophosphamide, dexamethasone, transplant, and consolidation. On an intention to treat analysis, a major finding and very, I would say, provocative finding in this trial was the rate of MRD negativity, which was actually similar between the KRD transplant arm, shown here, compared to the KRD non-transplant arm. And this is very important, because if we believe that MRD is a surrogate marker for survival, then it is likely that treatment which doesn't include a transplant step is likely to achieve similar results to a transplant procedure. So this will likely in the future question again the use of stem cell transplantation at the era of these powerful new induction regimens. And the auto-transplant field is likely also moving very quickly, because we had a presentation from a Chinese group from Suzhou, which actually tested the use of CAR T cells directed against BCMA, but also CAR T cells that are directed against CD19 after high-dose chemotherapy and auto-transplant. So a sort of consolidation with CAR T cells after auto-transplant. Of course, these are small numbers, but this study is actually showing the proof of concept and the feasibility of a consolidation with CAR T cells after auto-transplant, with a significant rate of MRD negativity. So overall, the transplant landscape in myeloma is changing very rapidly, whether you consider the induction regimen, the consolidation, or the maintenance approach. Now I would like to move to the frontline management of patients who are not transplant eligible, elderly or unfit patient. So during ASH 2018, in this group of patients, the major presentation was about the so-called Facon as part of the late-breaking abstract. This is an international randomized phase 3 trial in transplant-ineligible newly diagnosed multiple myeloma, comparing the standard of care with lenalidomide, dexamethasone given until progression versus lenalidomide, dexamethasone combined with the monoclonal antibody daratumumab. The primary endpoint was progression-free survival. More than 700 patients were included in this randomized trial. One important feature I noticed was the very high percentage of patients age above 75 years, 44%. Looking into the primary endpoint, you can appreciate the superiority of the daratumumab, lenalidomide, dexamethasone arm, where the median PFS was not reached, compared to the lenalidomide, dexamethasone arm with a median of roughly 32 months. At 30 months, you have 71% PFS versus 56%. So these figures of PFS with daratumumab, lenalidomide, dexamethasone actually have really set the bar very high for any drug combination in this treatment setting. When you look to PFS results in pre-specified subgroups, whether the ISS, whether baseline creatinine, ECOG, or cytogenetics, actually most the results are in favor of the daratumumab, lenalidomide, dexamethasone arm in the majority of the different subgroups. Looking into the response rates, actually 93% responses versus 81%, but most importantly, you have almost 25%, 3.4 times more MRD negativity in the daratumumab, lenalidomide, dexamethasone arm compared to lenalidomide, dexamethasone. And MRD negativity actually, irrespective of the treatment arm, is correlated with a significantly improved survival without progression. Looking into safety, I would say the safety profile was consistent with the findings from the previous trials which tested the use of daratumumab, lenalidomide, dexamethasone, namely the POLLUX trial, which was in the relapsed setting. Another important update we had during ASH 2018 in the non-transplant setting was the update about the ALCYONE phase 3 randomized trial. This is the trial which was published earlier in 2018 and which has established the use of DARA-VMP, daratumumab, bortezomib, melphalan, prednisone, as a standard of care in this elderly population. So in this update with a longer follow-up, we could see that the benefit in favor of DARA VMP was further confirmed, 60% at 2.5 years versus 28% PFS, with a very strong hazard ratio of 0.43. And looking again into the PFS benefit in the different pre-specified subgroup, we can conclude that DARA VMP can extend PFS across all subgroups analyzed. MRD negativity was also obtained and achieved with DARA VMP, roughly a similar rate to DARA RD, and whenever you can achieve MRD negativity, actually these patients are going to enjoy some very nice progression-free survival rates. While waiting for the results of the overall survival, one way of looking into overall survival would be to look into PFS2, which is the PFS a patient can achieve after relapse and salvage. And based on the PFS2 results of the ALCYONE trial, actually it is projected that DARA VMP patient, the patient from the DARA VMP arm, are likely to enjoy an improved overall survival to VMP. So overall, one can consider that in the near future, the Daratumumab-based combinations, whether with Lendex, DARA RD based on the MAIA trial, or DARA VMP based on the ALCYONE trial, are going to dominate the treatment landscape in the non-transplant setting. Having said this, we have seen during ASH 2018 some other interesting regimens that were tested in unfit and frail patients. One of them is this combination with ixazomib, daratumumab, dexamethasone. So you can see is a schema of the therapy here, followed by a maintenance part. This is the HOVON 143 study. And obviously, this is an interim safety analysis in 20 patients, 10 unfit and 10 frail. But the response rates are already interesting. The numbers are small, so I will not comment further on this. But most importantly, although we are in an unfit or frail population, actually the safety profile looks quite promising and may suggest that the use of an oral proteasome inhibitor such as ixazomib combined with daratumumab can be attractive in these very old or unfit patients. So that was the summary of the non-transplant eligible setting. Let's move now to the management of patients with relapsed or refractory myeloma. And this field is also moving very fast. First of all, using the already available agent, such as carfilzomib or pomalidomide, new combinations are being tested. This is shown here in this phase 2 EMN 11 study, testing the combination of carfilzomib, pomalidomide, and dexamethasone, KPD, as an induction followed by salvage auto and pomalidomide maintenance with or without dexamethasone. These are the response rates. Again, very nice response rates, more than 40% CR or stringent CR, and PFS rates. The follow-up is relatively short, but I think this study can establish the feasibility of carfilzomib, pomalidomide, dexamethasone combination followed by pomalidomide. We also know that the triplet combination of daratumumab, lenalidomide, and dexamethasone is becoming now more and more a standard of care in the relapse setting, thanks to the results of the POLLUX trial that were reported almost 2 years ago. During this ASH 2018, we had a very nice update about the PFS results from this trial. We have now a median follow-up of 44 months, and here we can see that the daratumumab, lenalidomide, dexamethasone combination allowed to prolong PFS compared to lenalidomide, dexamethasone in the intention to treat population, with a median of 44.5 months versus 17.5. This is a very high hazard ratio of 0.44, suggesting a 56% reduction in the risk of progression. So again, I believe these results are really very good. And actually, we can see that the bar is really very high now in terms of PFS, even in a relapse setting. And actually, newer combinations need to challenge this type of median PFS of 44 plus months. When we look into the PFS results of the updated POLLUX trial by cytogenetic risk status, actually the combination is effective. It doesn't allow to overcome 100% the high-risk features. Nevertheless, even the high-risk patients receiving DARA-RD are going to do better than the patients who are high risk but receiving only RD. So definitely this is an attractive combination for these patients. And actually, when it comes to high risk cytogenetics in the relapse setting, an interesting combination would be the daratumumab, bortezomib, dexamethasone combination, the DARA-VD. And during ASH 2018, we had the updated results of the PFS from this so-called CASTOR trial with a median follow-up of 40 months. And you can appreciate this huge difference between the daratumumab, bortezomib, dexamethasone arm versus bortezomib, dexamethasone. When you look into the results of this DARA-VD combination in patients who received only one prior line of therapy, so in another word, early use of DARA-VD, actually, as expected, the results are even better compared to bortezomib, dexamethasone alone. Looking into the different results of POLLUX and CASTOR and considering MRD negativity, again, the results are all in favor of the MRD negative group, irrespective of the treatment arm. So in another word, this is another confirmation about the prognostic value of MRD negativity in multiple myeloma patients, whether you consider the frontline or the relapse setting. When it comes to the relapse setting, it's not only about monoclonal antibodies and daratumumab. We have also some novel combinations. Venetoclax is making it rapidly into the field. We know it's already approved in CLL and AML, and actually now it's being tested successfully in multiple myeloma with different agents. This is a phase 2 study combining venetoclax plus carfilzomib and dexamethasone. You can see the different cohorts here, but the key message from this phase 2 study is about the objective responses in all patients and in those refractory proteasome inhibitors and IMiDs. And you can appreciate in all cases, we have more than a 70% objective response. And in all different subgroups, we have a relatively decent number of patients who could achieve stringent CR. Looking into the cytogenetic status, I'd like to draw your attention to this small group of translocation 1114 patient where you have 100% response rate, further supporting the use of venetoclax in this setting. Another interesting and attractive agent that was presented during ASH were the results of the so-called STORM trial, testing oral selinexor plus dexamethasone. So selinexor is an inhibitor of the XPO pathway, and this trial, the STORM trial, was performed in very heavily pretreated patients. These are the so-called penta-refractory multiple myeloma patients who received a median of 7 prior lines of treatment regimens. Despite being really end stage, actually we can observe a 26% response rate, including 2 cases of stringent CR who were MRD negative. So definitely a very promising agent. And obviously the next step would be to look into the combination of selinexor plus other agents. Here you can see the PFS results and the overall survival results from this STORM trial. Of course, CAR T cells are really the superstars of the ASH 2018 meeting, and we had several presentations about the use of CAR T cells in the relapsed myeloma. One of them is this so-called LEGEND-2 study from a Chinese consortium. The first results were presented at ASCO 2018. Here we have an update about the results of this trial. So these are patients with active multiple myeloma who relapsed on prior treatment. 57 patients were analyzed. Apheresis was performed. CAR T cells were manufactured. These are CAR T cells directed against BCMA, the so-called LCAR B38M. Patient received a lymphodepleting regimen with cyclophosphamide. These are the characteristics of the patient. You would notice that these patients are actually less heavily pretreated compared to some other CAR T cells trial in the relapse or refractory setting. Looking into adverse events, the most important feature is about the cytokine release syndrome, which is something very important to consider in the CAR T cell setting. 90% of the patients are going to experience some form of CRS. However, only 4 patients, 7%, are going to have a grade 3 and no patient with a grade 4. and the CRS was successfully managed with the tocilizumab. This is the anti-IL-6 receptor, which is the standard therapy for CRS. Looking into cells in a relapse setting. This is really a unique feature related to the use of CAR T cells, and it is likely that these good responses can be achieved irrespective of the level of expression of the BCMA antigen. The median time to the initial response was around 1 month, so relatively quick. And you can see the updated PFS of the patient achieving MRD negativity, 12 months. And this is now becoming roughly similar across the different CAR T cells trials in the relapse setting. Here we can see the overall survival analysis in these different subgroup of patients. For the sake of time, I will not be able to go through all the CAR T cells studies that were presented during ASH 2018. Here you have the references of these different trials. In all these cases, these were relatively small series, but definitely all of these studies could establish that CAR T cells are likely to become more and more widely used in the relapsed myeloma setting. Obviously, one needs to be aware about the safety profile, especially when it comes to the cytokine release syndrome and neurotoxicity. At this stage, we don't know what is the optimal CAR T cell construct, so this is really work in progress. Finally, in the relapse setting, I would like to highlight the results of this first-in-human phase 1 trial testing an agent called AMG420. So this is a BiTE construct binding to BCMA and CD3. So this is a similar story to blinatumomab, which is widely used and approved in acute lymphoblastic leukemia. So this BiTE technology, which can be available actually off the shelf, makes it really very attractive compared to the heavy logistics of designing or using CAR T cells. And for the first time, we had the presentation of the first results from 42 patients. So one important finding is about the maximum tolerated dose or dose-limiting toxicities. So the MTD of this agent was 400 microgram per day. And when you look into the safety profile, actually, there was only 1 case of grade 3 CRS, 2 cases of grade 3 peripheral neuropathy. However, I would like to draw your attention to 2 deaths which were neither deemed related to AMG420, but these are of interest. One was from an aspergillosis infection, and one from a liver failure secondary to adenovirus infection. Looking into the response rate in these heavily pretreated patients, of course, the study is still ongoing and many patients are still receiving the treatment. Nevertheless, we already have 7 patients who could achieve complete remission. VGPR achieved by 1 patient and a few other patients achieving PR. Another important finding is the rapid mechanism of action. The median time to any response was around 1.4 months, and the median time to best response is slightly less than 3 months. So this is really very attractive, very promising. This is a lot of hope to all our patients. I believe the outcome of multiple myeloma is significantly improving, whether in the frontline setting, elderly and young patients, but also in the relapse setting, including in patients who have failed already 4, 5, or 6 lines of therapy. The treatment algorithm are likely to change significantly in the near future, and the whole myeloma community and the patients are really very excited about all of these developments. With this, I'd like to thank you all for your attention, and I would be more than happy to take your questions. So please do not hesitate to ask your questions using the different tools you have available. So I have one question about CAR T cells in the frontline setting. So definitely people are very excited about CAR T cells. And the question is about, is there a rationale for using CAR T cells in the auto-transplant frontline setting? And actually, yes, this is correct. You're absolutely right, because the post-transplant period, especially after high-dose melphalan, from an immunological standpoint, is a very favorable environment for the expansion of the CAR T cells. And definitely using the CAR T cells for consolidation after auto-transplant is really very attractive in the setting. But at some point, as it is the case in lymphoma, one may wish actually to challenge the use of auto-transplant compared to CAR T cells. So this gives us a lot of exciting perspective when using CAR T cells. Now I have another question. I'm going to read it. If Daratumumab is going to be used only one time, which combination would you use with bortezomib or lenalidomide? So, well, I mean, it depends. If we're talking about one time in the relapse setting, I guess, well, actually, there is no rule. Obviously, the best results in the relapse setting using the triplet combination with Daratumumab are the ones we achieve with Daratumumab and lenalidomide and dexamethasone. So definitely, this is very attractive. Nevertheless, there are a group of patients who can clearly benefit from the Daratumumab bortezomib actually combination, either because of some contraindication to lenalidomide or even because they are refractory to lenalidomide. We know that in many places, patients are receiving lenalidomide maintenance until progression. So in these cases, actually, you may wish to use the Daratumumab, bortezomib, dexamethasone combination like in CASTOR. I have here another question. In your opinion, would BiTEs have a more widespread application than CAR T cells? Well, the short answer would be to say, well, the BiTE technology is really very attractive because when it comes to CAR T cells, Actually, it's a relatively complex procedure. First of all, you need the patient to have lymphocyte to be able to do an apheresis. Then it takes a couple of weeks to generate the CAR T cells, and obviously in some cases you may not be able to have the lymphocyte, to collect the lymphocyte, or to have to generate the CAR T cells. So actually all the studies that are reported are not reported on an intention to treat analysis. So in other words, we don't know how many patients were candidates to the treatment and how many patients actually received it. So given the complexity of the procedure, if you have immediately available BiTE antibody like the AMG 420, well, that looks very attractive. For the moment, we do not have any head-to-head comparison. I mean, it's a similar story if you compare in ALL, blinatumomab and CAR T cells, the CD19 CAR T cells. For the moment, you need both of them at some point. And I believe in myeloma, until further work is being done, we will need to continue the development of both approaches. Looking into the different questions that are coming progressively, there are a lot of questions. I'm not sure that I'll be able to answer all of them. I have one about, would you comment on the role of Tandem auto in high-risk multiple myeloma patients? Yes, this is a very good question, and actually for the sake of time, and didn't comment on it, but during the ASH 2018 meeting, we had a couple of presentations updating actually the results from HOVON and from other cooperative groups of double auto in myeloma. And it is likely that double auto is a good option in high-risk cytogenetics multiple myeloma. And actually, we are increasingly using double auto in these high-risk multiple myeloma patients. I have another question here. What is the role of mutational status at relapse for treatment selection? For example, BCL2 versus KRAS versus PTEN, etc. Well, this is definitely the future, I guess. It's not a common practice as far as I know, to look into the mutational status at time of relapse. But if at some point we would like to deliver personalized therapy, it is likely that we will need this, similar to what's happening in other hematologic malignancies and other solid tumors. And obviously, this will allow to guide our treatments. This is not available, and we are using treatments with a very broad mechanism of action. But we already can see that, for example, venetoclax is more active in some subsets. I have also another question here. In the setting of all monoclonal antibodies achieving very good results and moving to the frontline setting, what is the future of auto-transplant in myeloma? Well, this is a very good question. You know, every 5 to 7 years, with the advent of new agent, we are challenging the role of auto-transplant. For the moment, in the different randomized trials, auto-transplant was shown always to be superior in terms of PFS to the non-transplant arm. Also, I must admit that we do not have an overall survival advantage, and performance of late auto transplant is an option that is used by some colleagues. Now, I'm convinced that the role of auto will be again challenged with the novel quadruplet combination, and we've seen this in the KRD combination in the Forte trial. Of course, will continue to be challenged. However, we need to acknowledge that auto transplant is very highly cost effective in different places in the world, and even if it's only for this reason, I believe it will continue to be widely used. So we have plenty of other questions. We can spend the whole day or night, wherever you are, to answer them. Unfortunately, we'll have to close this webinar. I'll be more than happy to answer your questions by email privately. Please do not hesitate. I'd like to thank you all for participating to this webinar under the umbrella of the International Academy for Clinical Hematology. This is really a very exciting era for all of us hematologists. I wish you all a Merry Christmas and some happy end of the year holidays. Hope you'll enjoy some rest. With this, I'll say goodbye.